So our aim was to put together two groups, two multidisciplinary groups of obstetricians, midwives, anaesthetists, and other clinicians involved in the birth process to team up with our counterparts in Mulago. And we wanted to develop some guidelines that were context-specific, resource-neutral, and evidence-based in order to try to improve the outcomes, particularly of pre-eclampsia, but of other important causes of maternal mortality. But we came across a big problem with the third one of those, which is evidence-based, because, as we've already heard this afternoon, there just are very, very few data about maternal experience during pregnancy, about the mothers who give birth in Africa, and about their outcomes and what we can do about them. There are some promising starts though. One of the first things that we were able to use was Annette's wonderful data from her biological studies of the genetics of pre-eclampsia. There was an awful lot of clinical data collected by Annette and her wonderful team of research midwives at the same time that we hadn't analysed. And what we've done recently is to go back to that to look at and to figure out what we can say from that about the best ways to tackle pre-eclampsia in the Ugandan context. I just want to take you briefly back to the obstetric dilemma, the idea that small babies die in disproportionate numbers and large babies also die in disproportionate numbers. And what we've been able to do is use the specific Mulago data to look at that. And you can see that this curve, compared to the previous one, which was from a Western Scandinavian population, has got this significant left shift in it. It's the small babies that are a big problem here in Mulago. The number of large babies are much, much less. We compare that to our Cambridge population, just to show you for comparison, and again, the graph shifts back to the classical obstetric dilemma with that right shift that it has. I also want to point out from this slide the difference in the number of women we need to look at to draw these conclusions. From the Mulago context, we needed only 900 women to actually make good estimates of where perinatal mortality lie, whereas from a Cambridge cohort, I needed almost 38,000 women to draw the same kind of robust conclusions. And that in itself, I think, speaks volumes about the problems that are here in this setting. So we asked, can we use any of these data that we have, first of all, to predict the women who are at highest risk, and secondly, to say anything about how we might improve pre-eclampsia outcomes in Mulago. The data were collected in two separate collection points, and from that we were able to use the data from 1,200 women having their first baby who had severe pre-eclampsia or not. And absolutely fascinatingly, from 600 of those, we have very, very detailed information on their social circumstances, their education, their nutrition, and partner-related factors, which is a pretty unique resource in the sub-Saharan African context. And I just want to show you really what we have here. This is the phenotyping of the cohort. And the thing I want to draw your attention to is this. This is the mean arterial blood pressure of these women. Now, mean arterial pressure is better than using the systolic or the diastolic blood pressure because it gives a measure over time of where that woman's blood pressure really is. Internationally, it's recognised that over 125 is an obstetric emergency in itself, that something must be done immediately about this woman. It's rare to see it in our context. We here have the really well phenotyped over 300 women, all of whom had a mean arterial pressure of over 120 and an average of 130. So this is a truly unique resource if you want to study pre-eclampsia and its outcomes. It's staggering, the severity of the disease that these women are experiencing. And having that very, very detailed sociological, educational and nutritional perspective on these women has allowed us to make logistic regression models which again allow us to pinpoint where the risk factors really lie. And we can see that women who didn't have enough food during pregnancy and women who hadn't had any maternal education are at much higher risk than the general population. We also see that women who are of an ethnic group that's not common in the Ugandan context have a much lower risk than those who have an ethnic origin that is more common in the Mulago area. And that fits very well with what we know about other causes of maternal mortality and of perinatal death. But it's one thing to understand those risk factors. It's one thing to be able to say these women are at higher risk than others, and it's quite another thing to be able to do anything about any of that. And so what we've looked at is the risk that's attributable to risk factors that are modifiable. And the main risk factors that are modifiable are how many times a woman attends the antenatal clinic during her pregnancy and how much education she's had before she embarks on pregnancy. And those are two really important things that we can change about context. When we look at the risk of developing severe pre-eclampsia versus the number of times a woman attended the antenatal clinic, we find that attending the antenatal clinic is something that reduces the risk of severe pre-eclampsia developing. Those women who didn't manage to get to a clinic or who only attended once during their pregnancy were way above baseline in their scaled risk of developing severe pre-eclampsia. When we look at educating girls, this isn't quite significant, but we see a very similar trend. Those who didn't complete primary education, again, had a much higher risk of developing severe pre-eclampsia. The predictive value of these on their own is not yet good enough to be used absolutely in clinical practice, but in combination with the genetic research and pulling together all the other strands of what we're beginning to understand about pre-eclampsia, there's some really promising beginnings here in being able to pick out the women who are at highest risk and to make some inferences about what might help them. So we know that maternal education, maternal ethnic origin, and having enough food during the pregnancy do significantly influence the risk of pre-eclampsia. And it was great to go last week to Uganda, to Mulago, and talk to the antenatal clinic midwives and tell them our conclusions that coming to their clinic is associated with a lower risk of pre-eclampsia in the women. And they were delighted to hear that, and we were delighted to go and tell them that. Obviously, it's not necessarily a causal relationship, but there's certainly a correlation there between attending the clinic and having a lower risk of developing pre-eclampsia. There are lots of other outcomes that we're beginning to go on to look at. There are seasonality effects, there's effects on stillbirth, and all kinds of other things that we intend to explore through this unique data set in the future. The clinical collaboration itself between the two teams, what we tried to do was to develop context-specific protocols. They're based on international protocols and guidelines from elsewhere, but the real key here is to adapt them specifically for Mulago and for the context. And so far we've tackled 3 of the major causes of maternal mortality there. We've been through draft and discussion processes, and then we do training and trialling. These are skills and drills in the classic obstetric emergency sense, and that's really the way that we will use to embed them in the culture of Mulago Hospital. And then we return to revising them and developing ways in which we audit that practice and try to make sure that what we're doing really truly has the clinical impact that we hope it will. Our further plans involve collaborating with various non-governmental organisations. We're trying to develop multimedia health messaging to improve access to clinics and so on. And we have future guideline development and implementation plans, and we're very grateful to Addenbrooke's Abroad for making a lot of that possible. And of course, drawing together all the strands of what Ashley and Annette and I have all talked about, it's all towards this common goal of trying to improve the outcomes for the mothers and the babies, and drawing together the disparate strands of the genetic research on pre-eclampsia, of using the clinical data to identify risk, and using the clinical guidelines to have an immediate impact, all works together, and we hope that combining those approaches gives us a significant effect on maternal mortality. So I'd just like to thank everyone who's been involved with the project, to acknowledge Macquarie, Mulago and Cambridge, and of course Ashley and Annette, who have